Hello everyone and welcome to our module on seronegative spondyloarthritis. The word spondylo means spine and the word arthritis, as you probably know, means joint inflammation. So in disorders that are called a spondyloarthritis disorder, there is inflammation of the spine. And then the disorders we're going to talk about in this video are called seronegative spondyloarthritis, and they get the name seronegative because in these disorders there is a negative rheumatoid factor test. These conditions were originally thought to resemble rheumatoid arthritis, but they have a negative rheumatoid factor test, hence they were called seronegative spondyloarthritis conditions. And these are really a family of conditions, but they all share some common features, which we'll talk about in this video. And the conditions that are considered seronegative spondyloarthritis disorders are ankylosing spondylitis, psoriatic arthritis, inflammatory bowel disease, and reactive arthritis. And we'll talk about all of these in the next few slides of this video. All of the seronegative spondyloarthritis disorders are autoimmune conditions. They are all mediated by T cells, like this lymphocyte shown on the screen here, and they have an unknown trigger and unknown cause. Before we talk about the symptoms of these disorders, let me review some terminology. So when we say a patient has a monoarthritis, we mean they have arthritis involving one joint. An oligoarthritis is an arthritis condition involving 2 to 4 joints, and a polyarthritis is an arthritis condition involving 5 or more joints. Each of the seronegative spondyloarthritis disorders is a little bit different from the others, but there are some common features that are found in many of these disorders, and if you know what they are, it makes it easier to recognize these conditions in a board question. So the first feature that's common to many of the spondyloarthritis conditions we're going to talk about is asymmetric oligoarthritis. Patients with these disorders often have acute attacks of joint pain and swelling that often involve the lower extremities. They are asymmetric, meaning they only occur on one side of the body, and they are an oligoarthritis, meaning they involve 2 to 4 joints. So if you think about it, this is a very unusual presentation to present to the doctor with complaints of multiple joints on only one side of the body, usually in the lower extremities. For example, a patient may complain of pain in the hip, pain in the knee, and pain at the ankle. That's 3 joints. It's an oligoarthritis, and it's asymmetric on one side of the body. That's an unusual presentation, and it's classic for the seronegative spondyloarthritis conditions. And contrast this with rheumatoid arthritis, which is something that's often confused with the disorders we're going to talk about in this video. Rheumatoid arthritis is symmetric, meaning it usually involves both sides of the body. It's usually a polyarthritis, meaning it involves 5 or more joints, and it often involves the small joints of the hands. Other common features of spondyloarthritis conditions are shown in this slide. So in many of these disorders, there is axial spine inflammation. That's why they are called spondyloarthritis conditions. Classically, this involves the sacroiliac joints, which is in the lower spine and presents as lower back pain. Also, many of these conditions involve dactylitis, that's swelling of the fingers, classically described as sausage digits. This occurs because there's swelling of the soft tissue around the joints in the fingers. And then finally, enthesitis is inflammation of ligament and tendon attachments to bones. This often happens where ligaments insert into the heel, and this leads to heel pain, which is a common feature of many of these disorders. HLA-B27 is a human leukocyte antigen. In the immunology section in the video on transplants, I talk about the human leukocyte antigens. These are antigens that make up the MHC class 1 and class 2 molecules found on the surface of our cells. And there are genes found on chromosome 6 that determine each person's HLA type. For example, the MHC class 1 genes are HLA-A, HLA-B, and HLA-C. And each of us is born with a certain type of HLA-A gene, a certain type of HLA-B gene, and a certain type of HLA-C gene, and this determines which human leukocyte antigens will be on the surface of our cells. If you have the gene for HLA-B27, and therefore you have the B27 antigen on the surface of your cells, you are more likely to develop one of the spondyloarthritis disorders. This HLA type is strongly associated with many of the disorders we'll talk about in this video. For example, 90% of patients with ankylosing spondylitis have the HLA-B27 antigen. 50% of patients with psoriatic arthritis have this antigen. Now, there are many more people with this antigen who never develop ankylosing spondylitis or any spondyloarthritis disorder, so most people who are B27 positive will never develop disease. However, if you do develop disease, you are very likely to have the HLA-B27 antigen. So now let's talk about specific disorders, and we'll begin by discussing ankylosing spondylitis. This is the classic form of seronegative spondyloarthritis. It has many of those common features we talked about just a few slides ago. So this disorder is called a spondylitis because there's inflammation in the spine, and it gets the term ankylosing because ankylosis means new bone formation, and this occurs in the spine in this disorder, and that leads to stiffness of the spine, a hallmark of ankylosing spondylitis. This disorder is more common in males. In a board question, it will almost always be a male, and usually they are relatively young, 20 to 30 years of age when they present. The hallmark of ankylosing spondylitis is inflammatory back pain. This is found in 3/4 of patients. So inflammatory back pain is back pain that tends to occur in younger patients, usually under 40 years of age. It has a slow, insidious onset. It improves with exercise and does not improve with rest. And the pain is often present at night and gets better when the patient wakes up and begins to move. And the idea here is that these patients have inflammatory cells and inflammatory tissue present in the joints of their spine. So when they don't move, that tissue settles and stiffens the spine and causes pain. When they move, it breaks up the inflammatory tissue and therefore the joint moves more easily and the pain symptoms tend to become less. That is inflammatory back pain. Classically, the back pain involves the sacroiliac joint and leads to what's known as sacroiliitis. So the sacroiliac joint is shown on the slide here. It's the joint between the ilium and the sacrum. If this disorder progresses, it can lead to what's known as the bamboo spine. This is where vertebrae in the spine become fused from new bone development in the spine. That's what the term ankylosis means, new bone development in the spine. So to understand this process, let's look at this picture from the web shown on the screen here. So this is a normal spine with a vertebra and disc. When there's inflammation, that inflammation can involve the facet joint shown here. It can also involve the ligaments around the intervertebral discs. And over time, that inflammation can lead to bone protuberances, and that can eventually lead to a fused disc in the spine. And when you have fusion of the discs with bone growing over the discs, that is called a bamboo spine because it looks like bamboo on X-ray. And here's an X-ray of the bamboo spine. You can see that there's a white line here fusing the vertebrae together. So this patient has fused vertebrae. Their back is going to be very stiff and painful and have extremely limited movement. Enthesitis is another feature of ankylosing spondylitis. Enthesitis, as I mentioned earlier, is inflammation of tendon insertions into bones. Classically, this occurs where the Achilles tendon inserts into the calcaneus bone. So this is your calcaneus bone on your foot, and the Achilles tendon inserts into this bone. You can also see enthesitis where the plantar fascia on the bottom of the foot inserts into the calcaneus bone as well. So inflammation in either of these places will lead to heel pain, and that's a common presenting feature in ankylosing spondylitis, and that's because of the phenomena of enthesitis. Dactylitis also occurs in ankylosing spondylitis. This is swelling of the fingers and toes. This occurs when there is tendon and soft tissue inflammation around joints, and the fingers will look like sausage digits as shown in this picture on the screen here. And in addition to the joint and tendon problems, ankylosing spondylitis often has features outside of the musculoskeletal system. For example, many patients develop uveitis, which is inflammation of the uveal layer of the eye, and some patients even develop aortitis, which is inflammation of the aorta, and this often occurs at the root of the aorta, and that will lead to abnormal function of the aortic valve, so patients with ankylosing spondylitis can develop aortic regurgitation. And then finally, you can also see sometimes in cases of ankylosing spondylitis restrictive lung disease, and the idea here is that the patient's chest wall and spine are poorly mobile because of fusion of those vertebrae like I showed you before, and that can lead to a restrictive pattern of lung disease. This is an inflammatory condition, so on blood testing you will see elevation of the acute phase reactants. Most patients have an increased ESR and an increased CRP level as well. And so if you put all the things I've just told you together, you get the classic case that I've shown on this slide. In reality, ankylosing spondylitis is very, very rare, but in a board question it's probably going to look like what I've shown in this slide here. So it'll be a 25-year-old male with inflammatory back pain and heel pain from enthesitis, swollen fingers and toes from dactylitis. The ESR and CRP will be elevated, the patient will be HLA-B27 positive, and the treatment is with anti-inflammatory drugs. Usually NSAIDs are used, and in some cases, anti-tumor necrosis factor antibodies like infliximab can be used as well. Our next seronegative spondyloarthritis condition is psoriatic arthritis, and as the name implies, this condition involves arthritis that is associated with the skin disease psoriasis. This is a psoriatic plaque shown on the screen here. Patients develop many of these plaques on their body when they have psoriasis, and some of them, although it's a minority, less than 1/3 of psoriasis patients go on to develop psoriatic arthritis, which is one form of a seronegative spondyloarthritis. Patients with psoriasis can develop abnormalities of their fingernails and toenails. For example, they can develop pits in their nails, as is shown in this picture here. They can also develop oncholysis. This is when the nail separates from the underlying nail bed. This is a picture of oncholysis here. This white part should be just at the tip, but here you can see it's extending back into the nail bed. That's evidence of separation of the nail from the nail bed. You can also see hyperkeratosis, which is a darkening of the fingernail and toenails. Now, patients who have uncomplicated psoriasis, meaning psoriasis without arthritis, 46% of those patients have nail findings. But patients who have psoriatic arthritis, in addition to psoriasis, 90% of those patients have nail findings. So especially for a board question, if a patient with psoriasis is going to have psoriatic arthritis, they are probably going to have nail findings. So what are the clinical features of psoriatic arthritis? Well, it usually presents as an asymmetric polyarthritis, so it will involve 5 or more joints on one side of the body, and it can mimic rheumatoid arthritis because it often involves the hands, and patients often complain of morning stiffness that improves with use. However, rheumatoid arthritis is classically a bilateral arthritis. This is usually an asymmetric arthritis. A classic joint to be involved in psoriatic arthritis is the distal interphalangeal or DIP joint. So shown on the screen here is a person with swelling of their DIP joint. That's a classic joint to be involved in psoriatic arthritis. And then finally, these patients often have many of the other features of seronegative spondyloarthritis conditions. So they can have sacroiliitis and back pain. They classically have dactylitis. This is very common in psoriatic arthritis. Sausage digits occur in half of patients. And you can imagine if the hand is often involved, it's easy to understand why dactylitis is often a feature. And then finally, these patients sometimes have heel pain from enthesitis. There is a classic hand x-ray finding in psoriatic arthritis. It's called the pencil and cup deformity of the DIP joint. So remember, the DIP joint is commonly involved in psoriatic arthritis, and the distal phalange can become narrowed like this one is here. So people think that looks like a cup, and therefore the middle phalange looks like a pencil inserting into a cup. That's called the pencil and cup deformity, a classic finding in psoriatic arthritis. In the GI section, I have a video on inflammatory bowel disease, including Crohn's disease and ulcerative colitis. These are autoimmune conditions that involve the gastrointestinal tract, but you should be aware that both conditions are frequently complicated by arthritis, and in some cases, the arthritis has features of a seronegative spondyloarthritis. There are generally 2 patterns of arthritis that are seen in IBD. The first one is called the type 1 pattern. It involves usually less than 5 joints, and it involves the large joints like the knees, hips, and shoulders. And in this case, the symptoms often get worse when the GI disease flares. The type 2 pattern tends to involve more than 5 joints. It's usually the small joints of the hands, and this form of arthritis that goes with inflammatory bowel disease is often independent of the gastrointestinal disease. Now, in addition to these 2 patterns of arthritis, you can also sometimes see spondylitis and sacroiliitis. Rarely you can see enthesitis and dactylitis, and because of these features, the arthritis that goes with IBD is often considered a variant of a seronegative spondyloarthritis. The last disorder we'll talk about is reactive arthritis, and it's called reactive because it's an arthritic condition that follows an infection, and therefore it is reacting to the infection. It's a form of spondyloarthritis, and that means it's autoimmune, and this is important for your board. So if they describe to you arthritis following an infection, you might be inclined to think that that's spread of the infection to a joint. However, if it is a case of reactive arthritis, it's actually an autoimmune process triggered by the infection. This form of arthritis occurs days to weeks after an infection. There can be 1 or multiple joints affected, and it sometimes occurs with dactylitis and enthesitis, and that's why it's considered a form of seronegative spondyloarthritis. And usually this is a temporary condition. The symptoms resolve in a few months to a year. The bacteria that are known to cause infections that trigger reactive arthritis are listed on the slide here. These bacteria either cause a GI infection or a urogenital infection. Some of the GI bacteria that have been associated with reactive arthritis are listed on this slide. Most of these bacteria cause diarrhea, so the classic case would be a patient who had diarrhea followed a few weeks later by a reactive arthritis. In the urogenital tract, the classic bug to cause a reactive arthritis is chlamydia, so this will occur in someone who is sexually active. Remember, chlamydia is a sexually transmitted infection. The person may have urethritis and symptoms like dysuria followed by a reactive arthritis, but remember, in many cases, chlamydia infection is asymptomatic, so this could be someone who doesn't recall having an infection but develops a reactive arthritis, and only when you test the patient will you find out that they have been exposed to chlamydia. The musculoskeletal features of reactive arthritis are all the classic features of seronegative spondyloarthritis that I talked about earlier. So these patients develop an asymmetric oligoarthritis. It'll occur 1 to 4 weeks after infection, and it commonly affects the lower extremities, especially the knees. These patients can present with heel pain from enthesitis, they can have sausage digits from dactylitis, and they often have inflammatory low back pain. Now, in addition to the joint symptoms and the musculoskeletal symptoms, reactive arthritis often has other features outside of the musculoskeletal symptoms. One of the classic ones is conjunctivitis, so patients may present with a red eye. They can have dysuria from autoimmune inflammation of the urethra. Also, sometimes patients develop oral ulcers. And there's an old term called Reiter syndrome that's fallen out of favor. but this was taught when I was in medical school, and Reiter syndrome referred to arthritis, urethritis, and conjunctivitis following an infection such as one of the triggering infections we've seen before. Really, Reiter syndrome is just another form of reactive arthritis. It's an autoimmune attack to multiple parts of the body following a triggering infection. And that concludes our video on seronegative spondyloarthritis.